Usually it's stainless steel. Because you don't need to get them for a long period of time. It's enough if you make them with stainless steel, or you can use titanium. But what's about coating? I think that we don't need it really in these cases, because we usually change the hardware in 1 or 2 weeks.
Thank you very much.
Okay, thank you.
Now, I will request Dr. Sergei Ryok to give a talk on the spinal deformities.
Dear colleagues, it's very difficult to include spine deformity, any etiology in one lecture, but I have done try this. So a few words about spine deformities. What's have the problem, polyetiological, different specialized involved, orthopedic surgeon, chiropractic, physiotherapist, neurosurgeon, accompanying pathology, primary or secondary, absence of general approaches to treatment, using bracing, indication to operation treatment, questions of instrumentation, fixation, underestimate or overestimate treatment opinion. There are 4 groups, general groups of spinal deformity. More biggest group, idiopathic scoliosis, then congenital deformity, neuromuscular deformity, and systemic deformity. 2 general groups, structure deformity and non-structural deformity. The structure is idiopathic, congenital, metabolic, neuromuscular, post-traumatic, tumors deformity, and inflammatory disease. Non-structure, postural, hysterical, antalgic, and functional deformity. What approaches of spinal deformity, any etiology? I see that idiopathic scoliosis is general problem of cosmetics, and another etiology deformment, it's a problem of survive. Classification, why we used scoliosis classification to James and kyphosis, Kaplan and Winter classification. Age-related classification, infantile, juvenile, and adolescent deformity older than 10 years. What are danger of scoliosis? Of course, severe deformity, progressive condition, for example, idiopathic deformity, typical situation type 5 for classification Lenke, very rapid progression, congenital deformity, non-segmented bar of thoracic spine, X-ray on 1 year old and 5 years old, very severe deformity with contact between rib, chest, and pelvic. Rapid different protocol of progressive for idiopathic scoliosis, rapidly progressive, more than 10 per year, moderate 5 to 10 per year, non-progressive less than 5 degrees per year. Different approaches of congenital deformity, rapidly progress more than 3 degrees per year, non-progressive more or less than 1 degrees per year. Complication, of course, impressed spondyloarthritis, stenosis of the spinal canal, question quality of life if scoliosis is left untreated, investigation of Weinstein, had no family at about 10%, psychological problems at about 21%, more or less half part low back pain. At another investigation, psychological problem at about 20, pains 61, and 21 cardiac disease, 17% mortality, and 2 times higher than the average rate. Methods of treatment, it's typical physiotherapy, but is not effective in cases of congenital deformity, structure, systemic deformity, and neuromuscular deformity. Use the brace and spinal surgery, spinal fixation, and correction of deformity. Approaches to surgical treatment: one-stage correction, deformity control with growth, and hybrid approaches of combination external fixation or internal fixation. Malformation, one-stage correction, it's usually, for example, the male, 90-month-old, congenital kyphosis, type 1B for classification of Winter, due to posterior hemivertebra L1, stenosis of spinal canal, expectant tactics. It's more dangerous than the risk of operation. We use technique removed of pathological vertebra, decompression around of dural sac, correction of deformity, and instrumentation and bone plastic fixation. Another group of patient, deformity control with growth. For example, we using technical of growing rods. This situation using vector system by rib-to-rib system before correction of deformity of thorax, and rib to vertebra system before correction to spine. In patients with congenital scoliosis or due to multiple spine malformation. General malformation is disorder of segmentation. Hybrid approaches in patients with multiple formations, the disorder of formation, split vertebra, and disorder of segmentation. How I see curvature of lumbar spine, apex the curvature split vertebra, and basis the curvature hemivertebra. We use technique extirpation hemivertebra of T9, correction by spine-to-spine system. This part shortening technique, and this part we used distraction device of vertebra, and how I see good correction of deformity. Idiopathic scoliosis. one-stage corrections, typical correction of idiopathic scoliosis by using CD system with transpedicular screw. Deformity control with group is more biggest group, early older idiopathic sclerosis in elder patients, lanky type 4C and minus, correction by grooving rods to internal site of curvature, because expectant tactics is more dangerous than the risk of operation at less. It's another case, female, 14 years old, rapidly progressing idiopathic scoliosis, huge deformity. We used anterior release and posterior correction deformity with connector. Very severe group of patients with more severe idiopathic kyphoscoliosis. A biggest problem of ventilation deficit at about 22%. We used 4 technique, include 4 operation in 2 surgical session. One session, anterior multi-level vertebraectomy, and then putting on external device. We used transpedicular system, transpedicular external system, and then after one session operation, destruction for the using X-fix, and then 2 session who include posterior osteotomy by Smith-Peterson and correction and fixation of internal transpedicular devices. Metabolic deformities, it's the biggest group. 4 general groups: dysplasia, dystrophy, dysplasia dysostosis, and chromosomal deformity. For example, achondroplasia, progressive kyphosis. We used 2 general problem of in patient of achondroplasia. The vertebral syndromes include spinal kyphosis deformity and rare congenital spinal stenosis. We used a hybrid approach, combination of neurosurgical approach with laminoplasty of French door and correction of deformity. We used laminoplastic and good correction of kyphosis deformity. Spondyloepiphyseal dysplasia, manifestation plasiospondylia, angular kyphosis, and non-congenital secondary spinal canal stenosis. Very huge deformity, angular, severe lower paraparesis. We used only deformity correction and stabilization by CD system. In this patient, neurological symptoms regressed to middle paresis. Another patients with Harrell's syndromes, mucopolysaccharidosis of type 1, severe kyphosis, paraparesis type D. Delayed procedure would result in plagia. We used segmented correction and fixation of deformity. This patient's how I see this patient in presentation of Professor Gubin, female, 12 years old, severe kyphosis due to neurofibromatosis, neurofibroma on the apex of deformity, high risk of neurological problem after operation, and we used stage first session only fixation and correction by external transpedicular fixator, and secondary surgical session, stage 1 thoracoscopic release and removal of external fixation and CD deformity correction with connector, because the female only 12 years old. A deformity correction of 17%. Neuromuscular deformity, the orthopedic manifestation, you know, it's deformity spine, thorax and lower limbs, and spine manifestation, huge kyphoscoliosis, lumbar versus thoracolumbar apex of the curve, torsion of the thorax in incorrect pelvis position. All my patients has type C or D with incorrect pelvic position. Principles of treatment in these patients include spinal fixation with instrumentation. It's a standard treatment of the general treatment of these patients. One-stage correction. For example, Oppenheim disease, severe neurogenic progressive scoliosis, severe mixed theta paresis, right angle of deformity. We used only correction, only posterior correction deformity. The patient was able to sit after operation. In patients with severe ventilation deficit, we used hybrid approach. How I see space available of lung is very small. Stage treatment at first stage, holopelvic device, and the secondary stage, correction and posterior fixation by CD fixator. We include in the zone of vertebra from T2, T3 to S1, S2. A typical location of curve: severe cervicothoracic scoliosis, for example, myelopathy of Salima disease, severe atypical curve, high risk of neurological symptoms. Combined technique, we used holopelvic system and fixation, combined internal fixation with cervical and classical CD transpedicular device. Indication of surgical treatment: deformity angle of more than 14% degrees of scoliosis and 20 degrees for kyphosis. Rapid progression, deteriorating visceral organ function, neurological disorder, static and dynamic imbalance, and cosmetic defect. Thank you very much.
Session is open for the questions. If anybody wants to ask any question, is more welcome. Dr. Jha, will you like to have some questions? Please come into the mic, please. Please introduce yourself then, please.
Well, I am Mrs. Jha from Patna. Well, I am interested to know, when you do an X-fix, is there a time gap between your removal of X-fix and definitive intervention?
It's usually 10 or 14 days.
It is not on the same day that you remove it and you fix it.
In the same day. In the same day. Yeah.
Same day.
Yeah. Yeah.
Okay.
Yeah.
Put it, then we make all restorations, all the corrections, and it takes usually from 1 week to 2 weeks.
No.
Then we
Yeah.
go to internal fixation.
So
Yes.
you have made
It is-
percutaneous holes, and if you do fixation on the same day after removal, is the infection rate higher?
If you do this in 1 week or 2 weeks, it will be okay. So it's why you must use it replace it very quickly. If you will do it after 1 month, you'll have
And this period we used distraction and reclination, step by step, each day.
Thank you, Dr. Sergey, for a nice talk. Now invite Rajat, spinal illizarov in India. After that, we will.
An aid, and the stare I got from all the spinal surgeons was, "Are you an alien?" So I thought to present it better in illizarov surgeons. The current treatment options in use in any spinal pathology is either observation, conservative, or surgery. With the current surgical techniques, sometimes there is limitation of correction, a minimal acute correction achieved during surgery and when the correction has to be big. There is always a risk of neurological injury during the surgery. Exposure is sometimes extensive, and there is always a risk of spinal instability. To our knowledge, our study is one of the few reports of the use of the external fixator in the spine. We got some of the articles which were published, and here we present our early results. The objective of our study is to demonstrate the versatility of the external fixator as a reliable option for the treatment of spinal pathologies and to stimulate further research in this direction. The general principles of treatment of correction are same as illizarov. Deformity should be viewed in all 3 dimensions. All components should be considered in the correction. And to obtain a 3-dimensional correction of the deformity by translation in AP and lateral view, distraction, derotation, then gradually correct the deformity to achieve the full correction, and then stabilize the unstable segments by bony fusion and internal fixation. Up to now, we have treated 24 cases, 9 cases of spondylolisthesis, 7 cases of kyphosis without neurological. Our inclusion criteria is kyphosis without neurological deficit. Out of that, 5 cases were of compression fracture of T12 L1, 1 case of L2 fracture, and 1 POTS, and 8 cases of degenerated disc. The male to female ratio was 11:5, mean age was 29.3 years, mean duration of symptoms was 26 months, and mean follow-up currently is 2 years and 8 months, from 6 years to 18 months. First, our surgical technique. What are we doing? We are using a local anesthesia, just a plain xylocaine. We don't use any short GA or any GA. With the biggest advantage of local anesthesia is when you are putting the pins, you are very safe, because if the pin will touch the root, the patient will immediately complain of radiation in the pain. So at any time you can change the track of the pin, at least you will not do any harm to the patient, which is the chances are very high in cases of percutaneous spinal surgeries. We use a double C-arm in our OR for simultaneous AP and the lateral view. This is very important, because with every rotation of the pin, you should check the direction of the pin track, whether it is in the center of the pedicle or not. And if you have one C-arm, every time you will be rotating, and after some time you will get tired and you will think, no, I am going in the right direction, so let's do it without C-arm. And that is the time when you make a mistake. Because in spinal surgeries, even a 1 or 2 millimeter track change can lead to a disaster. So it's always good to you have a double C-arm. It will shorten your duration and it's very convenient. So as in the picture you can see, there's a C-arm of the AP view and simultaneously there's a C-arm for the lateral view. So what are we doing? We are passing a 2.5 millimeter wires in the center of the pedicle in AP and the lateral view, as with any pedicle screw fixation in fracture cases. Over the wire, we pass a cannulated translucent pedicle awl to make the hole. This is the point when the patient gets usually the pain. As the awl makes a hole in the cortex of the pedicle, for initial 4-5 seconds, the patient has pain. When you make a hole over and then you remove the wire, now you have made the hole, so you are pretty safe, and you apply 5 mm pedicle half pin Schanz pins as with any illizarov fixator. The pins are connected by the spinal plates, you can see in the figure shown there, and there are special spinal fixators which connect the plates to the pins, and both the plates are connected by a threaded rods. So this is a very simple construct. 4 pins connected by 2 plates and 2 plates connected by threaded rods. This is the basic construct. Any person who is doing illizarov and who is doing normal pedicle screw fixation in fractures can do this immediately. So this is all the instrument assembly which is needed. You need spinal plates, pin fixators, Schanz pins, a pedicle translucent awl, a T-handle, and some bolts and nuts. This is the whole assembly you need. Nothing else. In fractures, we are doing the acute distraction on the table as we do with any pedicle screw fixation internally. In cases of listhesis, first we gradually correct the deformity from day 2 and we start from day 5 to 7. In cases of prolapsed disc, we do a gradual distraction starting from day 3. In the post-op period, a typical finding what we have observed that in most of our patients, as soon as on the day 1 when we distract the spine and the spinal canal volume is increased, the patient gets almost 50% relief. And then we continue doing the gradual anatomical correction of the deformity. Usually take 1 to 3 weeks depending on the severity of the deformity. We promote the patient to start walking from day 3. The patient is encouraged walking in the hospital, going to the canteen, doing all the routine activities. It helps to alleviate any psychological problem, and the patient is encouraged to do all the daily routine activities. We do not discharge the patient. We ask him to he can roam around in the hospital. And every day we are monitoring continuously for any neurological deficit. We frequently ask the patient if he is having any other radiating pain in the legs or any other problem. In the post-operative patient, in the period when we are doing the gradual distraction, and when the patient says, "Now I don't have any pain in the legs, there is no radiating pain," at that point we correct the deformity a little more, and then we send the patient home. And usually we keep the fixator for 2.5 months. In cases of listhesis, a second stage surgery is needed. Once the gradual anatomical correction of the deformity is done in 1 to 3 weeks, then the fixator is taken out and the pedicle screw fixation with fusion is done after the correction of deformity. So listhesis patients don't go from away in a hospital. When they become completely free and they are totally satisfied, then we remove the fixator and we have to apply a pedicle screw to maintain the reduction. If there is any method by which this reduction can be maintained, there is no use but this is the only method available currently to have a pedicle screw. Many times the patient asks that we don't need a second surgery. You just remove the fixator, we are fine. But we have to apply the pedicle screw, otherwise it will lead to a relapse. We don't do any laminectomy or any decompression, anything. We just put the pedicle screw just to maintain the correction what we have achieved. After the frame removal, the gradual spinal exercises are started, especially the spinal extension exercises. That's very important when the patient is pain-free and now is fit. We have to make the patient to understand that now if he doesn't follow the good spinal habits, disease will recur. So every staff in our hospital, he enforces the patient that now you have to follow the good habits, like sitting straight, thin mattress, no heavy weight lifting, no long work and forward bending. Many of our patients have jobs which have 8 to 10 hours of sitting. So we ask them, if you can't change the job, after half an hour of working, at least you can take a break of 2 to 3 minutes and just extend your spine. So here are some cases. This was a case of fracture L2. Neurological status. One of the inclusion criteria in all our fractures, that these are neurologically stable fractures. If there's neurological involvement, we go for the traditional open decompression. Currently what we usually do, we apply a spinal spica or a pelvic traction and make the patient lie for 2 to 3 months in the beds. But in these cases, we ask the patient to walk from day 3. So this is the simple construct as I showed earlier. 2 pins above, 2 pins below, connected by plates and distraction. So this was the post-op X-ray, and the final X-ray, we just distracted the pins, and after 2 or 3 months when the fracture has consolidated, we remove the pins. And we achieve a kyphotic angle 0 degrees. This is a case of listhesis. This was our first case, listhesis L4, L5. Initially we applied the fixator and then we gradually distracted. When the deformity was totally reduced, we just removed the fixator. We kept the fixator for 2 months. We thought that there will be a fibrous ankylosis or something and it will maintain the fixation. So we just removed the fixator and we didn't apply any internally pedicle screw. So this patient got a relapse after 4 to 6 months. So by this patient we decided that we have to internally fix. So this was our subsequent case. This is L5 S1. Initially we gradually corrected the deformity and we applied 2 pedicle screws to maintain, but nothing, no decompression, not any bony removal, nothing was done. A similar case, a very severe case, grade 3 spondyloptosis. We gradually distracted the deformity, gradually corrected the deformity, and later on we did a pedicle screw and a fusion. You can see that the deformity was totally reduced. And these type of cases are pretty, I don't know whether it's pretty difficult to do it in one stage acute setting. Now the very simple pathology, the prolapse disc. Like in most of our backache cases, majority of the cases are those who are not getting treated by the conservative treatment, and in the MRIs you don't see a very large disc and that you straight away go for a discectomy. So there are many patients who are not getting relieved by other epidural steroids or bed rest or medicines or anything, and either they don't want surgery or you also don't feel that the disc is such big. So our traditional teaching was to apply a pelvic traction in these cases. But pelvic traction, the concept was to apply a distraction at the disc side, but pelvic traction is gradually non-effective. So what we have applied, we have applied the principle of pelvic traction to give really an actual traction at the disc side. This was a case of disc L4, L5. We just applied 2 pins above and 2 pins below and we distracted. So this causes offloading of the disc. There was no mechanical pressure from the disc was released for 2 months, and we gave the disc a chance to regenerate. The current treatments are either you excise the disc or you replace the disc. But this is not the ideal treatment, to remove a body part or replace it. Our concept is to first just give a chance of the disc to regenerate itself. If it works, it will be very good for the patient. So this was a case of the MRI. We did post MRI after frame removal in 3 of our cases. The above one is the pre-operative MRI. It was a disc L4, L5 with decrease in the disc space. We applied the distraction for 2 months and then we removed the frame, and then we did a repeat MRI. And we saw that the water content in the T2 image increased. It was showing the signs of regeneration. We extended our applications further and we tried it in a POTS case, severe kyphosis, 85 degrees. We applied the scary looking fixator and we tried to correct the deformity, but we were able to achieve only from 85 degrees to 58 degrees. So we don't recommend these type in further. The results in kyphosis, 7 fractures and 1 POTS. There were initially different kyphotic angles, 13, 23, 15, 85, and in fracture cases we achieved in all 0 degrees. In Lester's cases, grade 1 and 2 is not a problem. You will always achieve 100% reduction. In grade 3, our 2 cases, one which I showed, we had 100% reduction, in other one, we got only 50% reduction. In degenerated disc, this is very interesting that after frame removal, we had 8 cases, and all 8 cases have yet not reported for any recurrence. And our maximum follow-up is 20 months. But for this treatment option, the patient selection is very important. Our inclusion criteria is a patient is having any backache with radiation, sciatica or anything, which is not responding to conservative treatment for 6 months. Obviously, first we have to try for all the conservative method like epidural steroids or tractions or anything, pelvic traction thing. And if there is an illogical environment like a weak EHL, then we go for discectomy. So we are applying spine illizarov in the cases in the middle, which are not responding to conservative and which are not a very good indication for the surgery. And the majority lies in this group only. The advantage of spine illizarov, there's a gradual correction of the deformity in all the planes. We are doing it in local anesthesia, so we are very safe. A very good advantage, there is a continuous neurological monitoring during the surgery when we are applying the pins, and even post-operatively during the gradual correction. There is no spine instability, we are not removing any bone, we are just regaining the anatomy, and there is anatomical correction. Potential complications, as with any method, wrong positioning could injure the nerve roots, hence detail has to be given to the anatomy of the pedicle. The pins may loosen and it should be checked regularly. Painful pins are likely to be the loose pins. And a very important potential complication is infection. Pins may get infected as with any illizarov fixator. Pin tracks has to be cleaned regularly and kept dry. We got infection in 2 cases, but luckily both were superficial and healed with curating and antibiotics. What we think that there is a very good spinal muscle bulk between the skin and the bone and a very good blood supply. So that's maybe the reason that we up to now we haven't got any case of any deep infection. Now what we have to see in cases of prolapsed discs where we are using distraction of the disc space by a spinal illizarov, whether relapse will occur after the frame removal. Even if relapse occurs, let's say after 1 year or 2 years, we haven't burned any of our hands. The current methodology of disc excision or replacement can be applied any time. We haven't done any cut any hand or something. If relapse did not occur, then we have given an anatomical treatment. We have tried the principle of regeneration of the disc. To conclude, spine illizarov is another option from the treatment of listhesis. Spine illizarov gives a chance to regenerate and repair the prolapsed disc in comparison to current treatment of discectomy or disc replacements. And it is a good option to spinal compression fracture without neurological deficit in comparison to the spinal spica or 2 months of pelvic traction. Obviously, a further research is needed in this direction. Thank you.
Any questions?
Yeah, because its pedicle is very small and we have already applied a 5 mm pin. So there is no other chance of putting another pin. So we have to apply in the same track.
When you remove the external fixator and put an internal fixation, the chance for infection goes very high.
Yeah, the chance for...
Discussion about external fixators begins to interlocking.
Yeah.
They would say you wait 3 weeks, 6 weeks, 3 months and all that. In spite of that, they get infected. So here on the same day, if you remove an internally
Actually,
the chance for infection.
yeah, in one case we tried to, we removed the fixator and we thought to do the surgery after 3 days. But after 3 days, even when we put the patient on the OR and we checked with the C-arm, the deformity relapsed by 20%. Just in 3 days. What we achieved in 2 months, relapsed in 3 days. So this is obviously a, but in our 7 cases we haven't yet seen. 2 cases had superficial infection, but this is a potential complication, I agree to it.
Thank you, Dr. Rajat, for your nice paper on spine illizarov, first time in India. Now we are having spine illizarov workshop.
purpose. So, and the next thing is the potential of these mesenchymal stem cells to transfer for the transformation into daughter cells, which are essential for the osteosynthesis. And these bones, these osteoporotic bones, they have a lesser response to the mechanical stresses which promote, meaning for the remodeling as effect, they have less response to the mechanical loading. And at the end, as we know, it is a less bone mineral density bone. So naturally less holding power of the bone to the wires or pins, and the strength of fixation is also less. So these are the issues which we have to take into account. So certain how to manage in this scenario, background, how to manage these fractures or the non-unions, fracture non-unions. So it has divided into preoperative phase, peroperative, what precautions you take, and post-operative phase. In these three things, we should give a relatively a better or a desirable result despite some difficulties in fixation and management. The first thing, as we know, it is not at all an emergency condition, will have ample time for the treatment. So better thing is, if possible, we have to put a POP casing for the non-union, ask the patient to load the limb for a span of about 1 month like that, so that to some extent the osteoporosis will come down. And at the same time, you ask the patient to promote some muscle strengthening exercises. And the medication aspect is important. Injection vitamin D, which is available in 6 lakh units, 1 cc injection, and various osteoporotic drugs, as we know, need not go into the details of those. Okay, and coming to the surgery, the first thing is you have to use more number of wires instead of shank pins, especially the olive wires. Olives can be used with washers, but the difficulty is insertion of these washers, some difficulty, and at the same time removal is also a problem. And the second point is these wires ought to be widely spanned in the sense, if you take the long axis of the bone, length of the bone, maximum length of the bone to be covered with wires to be passed, and you have a maximum purchase or a long working length of the long working length of the bone. So on the right side you can see, if we, in general what we do is, if this is the ring, we will be concentrating the wires at the same level, but in this we have to use as much bone as possible with help of a drop wires, and you have a maximum purchase of the bone in order to have a good stability. So this is one thing, and we should have a very low speed drilling, because as the bone is highly osteoporotic, so speed of the drilling, if it is more, that may produce thermal necrosis and loosening of the wires. So it's a very low speed drilling, and sometimes just hammer the wire, that is also sufficient depending on the severity of the osteoporosis. And second thing is, we can use shank pins depending on the stability of fixation, and better thing is, nowadays taper shank pins have become common, and 5 or 6 mm shank pins can be used, and the best one is the hydroxyapatite coated shank pins. Even though they are relatively expensive, they give good amount of stability to the fixation. And the only difficulty with these shank pins is sometimes removal is a difficulty. Sometimes you have to subject the patient again to anesthesia for the removal of these pins. And while passing the shank pins, use a undersized drill bit, less than what is desired in the normal bones. Sometimes drill bit usage is also not needed depending on the severity. And osteoporosis is not generalized in the sense, if you take tibia, the first part affected by osteoporosis is metaphyseal region, and the last part to be affected is the diaphyseal region. So use that part of the bone which is less osteoporotic to have a good purchase, and then less number of wires in that part of the bone which is having more osteoporosis. So and another point is joint spanning. For example, if you take the lower end of tibia, it is better to go to the ankle, span the ankle, fix the calcaneum or the talus or the foot in order to have a good good stability. And the other thing is reduce the weight of the fixator by means of composite or the carbon fiber rings and titanium pins. That will reduce the load on the limb, because if the load is too much, what happens, there is a possibility of perifixator fractures. So reduce the load, especially these perifixator fractures are common in severe osteoporosis in femur. So reduce the load of the fixator, and it can be used composite hybrid fixation like that. Sometimes the elastic pins can be used in humerus or the tibia or whatever femur in order to have some little bit of additional stability which they are going to give for us. At the same time, it is not very difficult for us to pass shank pins or the wires over this wire, over the internal fixation device. It also helps in maintaining the reduction, and it allows compression longitudinally. So it can be used if you desire it. And then comes how the shape of the bone should be in osteoporotic bones, and adequate contact should be there, or maximum contact if possible it should be there, and the stability has to be assured, and impaction factor is one thing, but sometimes it is not, all the time it is not possible. And I told it should be load sharing type. If there is a good impaction, good compression, some amount of load will be shared by the fracture, which is good for the union purpose. And compression it depends on the geometry of the fracture. It should be a side to side compression sometimes, because if you do vertical compression, there will be a possibility of displacement, not to go for resection, because that will cause loss of limb length. So you can do compression by putting translation devices in this fashion, mediolateral compression or anteroposterior compression. If it is transverse, you can comfortably give a vertical longitudinal compression. And another thing, as these have a very poor osteogenic potential, so it's many times better to think of autogenous cancellous bone grafting, which is proved to be a gold standard in these non-unions. It reduces the fixator time. Osteoporosis will also reduce with the bone grafting. At least at the fracture site, the osteoporosis is reduced, and it enhances osteosynthesis. And comminution, it is better to do compression at the cost of certain degree of loss of length, which can be countered by corticotomy if desired. That is more than 2 centimeters or 2.5 centimeters, you can go for corticotomy and comfortably get the lost length. And post-operative phase, it should be a very gradual compression. No, it should be very gradual, because if you do a faster compression, that may cause an additional fracture in severe osteoporotic bones, and sometimes there will be a cut through of the wires also. So gradual compression depend on the geometry. And as you see, even though the Wolff's law, which is a very important thing, basic law, mechanical forces are converted into biochemical signals which have a stimulation on the osteocytes, which promotes this bone remodeling. So based on this, if there is good amount of compression or the desired compression, there will be bone remodeling, and osteoporosis may burn out with this compression. So compression is very important in these fractures, non-unions. So, and the post-operative phase, physiotherapy, loading and moving, load and motion, loading and moving the limb, and weight bearing exercises. Exchange wiring is one we have to think in post-operative phase, because there is a high chance of loosening of the wires. And as usual, pharmacological measures, dietary high protein diet and high calcium diet, and general measures to be undertaken. And the complications or delayed unions is well known, and failure of osteosynthesis, and fracture at the shank pin sites, and perifixator fractures, is a possibility. So, and some of the case studies, you see this is a long-standing gap non-union with tapered atrophic type in a young patient with delay 3 years old non-union with loss of bone at this point. What I told is a load sharing type. In such cases you need not do any excision. Just if it is aseptic, you need not go for debridement, just align it properly and pass through this bone. So these reductions are very stable and gives some load sharing effect. So it is not all the time a possibility, but sometimes this gives load sharing effect and decreases the load on the fixator, and at the same time you can do a corticotomy is done here to restore the limb length. And this is a old lady with simple non-union as a severe osteoporosis. In such cases you can do mediolateral compression or the at the same time oblique compression. You see the after union the osteoporosis has come down. And this is another humerus non-union with osteoporosis, female patient. And in this case a nail has been passed to have some additional support apart from the fixator, and bone grafting is also done in this case. And here is a severe segmental type of non-union humerus, severe osteoporosis. Again the nail has been passed and adequate compression is given along with the bone grafting. Fracture united, and of course with some malunion, but united well. And finally the thing is, all the basic principles of fixation, which gives good stability, all the basic illizarov principles have to be given utmost priority. They do remain the same. These are only the additional things which I have emphasized. To conclude, this illizarov fixation in osteoporotic non-unions of long bones, it provides a stable fixation and a successful outcome if some special principles of fixation and management are followed. Thank you. Fixator, bone cement means hydroxyapatite coated. At the fracture site. Bone cement at what point? That is a non-union site. Yes, sir. Huh. Huh. Okay. At the Shanspin site. No. That non-union, we want promotion of union won't occur if you put at the fracture site. It will not pass through the fracture. But all around you can fill the site with the cement, liquid cement or something like that. So that? Then you fix it from outside or from any implant. Okay, putting bone cement. For external fixation or internal? External or internal, but you use the cement just to strengthen the bone. And put an implant, maybe internal or external.
What he is asking is, in some of the grossly trochanteric fractures with osteoporosis, along with DHS fixation, they put bone cement also, so that it does not fail. Screws at the point of screws. Surrounding that area where there is a... Okay. Right. Around okay. The bone. No. It is put in inside the also they put it. When you remove, say, an osteoclastoma assist, you are fixing it with a DHS. To prevent a fracture, you put in bone cement also. That is a known method of treatment. He is asking you whether you are doing that surrounding the non-union. That is for internal fixation. Give more stability. That is for internal fixation. For this external fixation, for the fracture, whether you are using cement on top. No. This is what he is asking. No.
Okay, thank you very much.
It's very simple. it's very simple for me. The first stage we take nails and no incision. We introduce to skin and feel of bone structure. It's usual. I feel transverse processes and medial part cross to lateral facet of articular. This point of introduce. At them. No, maybe more medial. Fixed. And more. Another side. It's a safe procedure of another side. X-ray control on the anterior posterior side or frontal. No delete. No. I see where is position of apex.
How deep it was?
At them, I take these instruments. Small incision. Around. Around of nails.
The length of the wire is
It's a marker basically.
Yeah.
You use such long wires or you use smaller wires? That is only
Marker as well.
It's marker. It's marker and introducer. Take introducer more, less.
Same way.
What should be the angle of
The typical angle, different.
patient is kept prone. Kept prone.
It's in lumbar spine. It's usually angulation of lateral at about 15 degrees, 20 degrees, and sagittal plate in the middle segments of lumbar, 0, and its position different position of table of patients of table, but it's usual middle or the vertebra of lumbar. It's 0. It's typical position. It's typical position on the upper segments. Yes, at about 10, and and this
Lower lumbar.
Number. Usually I put in illosacra at about in lateral mass through the C2. S2. It's this position not comfortable connecting of base of external fixation, and secondary point at point of pelvic. Iliac crest. Posterior iliac crest.
Iliac crest and another in one.
It's at this point who we used who put in of chance screw. It's the same position. Very comfortable for connecting this system. This at them I make incision to skin